Hi everyone, in this video I'll be discussing the targeted therapy in anti-cancer drugs. Now, when we started on the anti-cancer topic, we told you that there are certain drugs called cytotoxic drugs and they are going to kill normal as well as cancer cells. So the adverse effect is going to be more. Now, as we started doing research more and more, then we started realizing that there are certain targets in the cancer cells. If we target that, we are going to kill more cancer cells and the normal cells will be spared. With that background in the mind, then we started doing research and we started getting more and more targeted drugs for the cancers. And later it was also found out that why can't our immunity kill the cancer cells? When we have immunity, you can tell the immune cells, go and kill the cancer cells, they are not good for us. But why are we not able to kill them? Then we have another important thing. They are called as immune checkpoint inhibitors. So we will make the cancer cells to die by our immune cells. How do we do that? We'll understand in this topic. So, targeted therapy, how to target only the cancer cells. Let me take the example. Now, we have studied a receptor called tyrosine kinase receptor. So, tyrosine kinase receptor, we know that this is the tyrosine kinase receptor. This is the extracellular domain. This is the intracellular domain. There is one more receptor. So, they are nearby. Now, you know that these tyrosine kinase receptor, they have intrinsic tyrosine kinase property. Whenever the growth factors bind to this, whenever the growth factors bind to the receptor will undergo dimerization and they will phosphorylate the tyrosine kinase. So they have intrinsic tyrosine kinase property and this will activate the intermediate pathways. And these intermediate pathways will give the signal for cell proliferation. Cell proliferation. So this is the understanding. So whenever there is growth factors, for example, epidermal growth factor, vascular endothelial growth factor, these factors will tell the cancer cells to proliferate. How do they communicate? They communicate with the help of the receptor tyrosine kinase. So again, we know that the growth factors are the one which are stimulus for cancer to proliferate. Then the scientists thought, why can't we block the growth factor? So number one, you can block the growth factor. That is one thing. Second, what they did is they blocked the tyrosine kinase. Then they also blocked the intermediate pathways. So they started blocking these pathways. So basically, the growth factors can be blocked by using MAPS. Now, what is MAPS stands for? MAPS stands for monoclonal antibodies. Now, these will attack the growth factors wherever they are, they will block them. If growth factors are blocked, they cannot bind to the receptor, the cancer cells cannot proliferate. For example, there is a growth factor called HER2/neu. HER2/neu is a growth factor for breast cancer. Now, if I block this, HER2/neu is blocked by using a monoclonal antibody. Then what happens? They cannot bind to the receptor and they cannot cause cell proliferation. So the first one which came to the market, it is called trastuzumab. It is also called as Herceptin. So this is the one which blocks that HER2/neu and it is used to treat breast cancer. It is used to treat breast cancer. So like this, we started targeting the growth factors. So they are called as monoclonal antibodies. Remember, these antibodies are proteins and we cannot give them oral. So these are not given oral. So they should be given parenteral only because they are MAPS. Then the scientists thought one more thing. Suppose tyrosine kinase is also responsible to increase the signaling pathway. Why can't we block this? Then we came with tyrosine kinase inhibitors. Tyrosine kinase inhibitors. Now the specialty of tyrosine kinase inhibitors is you can give this drug oral. These are oral drug and usually they end with nib. Their name end with nib and you can give them oral. And very easy to administer to the patient and they end with nib. Now the intermediate pathways are also can be blocked. So there are drugs which can block the intermediate pathways also. So we'll discuss them later. Okay, so we'll discuss them later. So there are blockers, the drugs which can block the intermediate pathway also. Now these drugs, what I have written here, the one which blocks the tyrosine kinase and the intermediate pathway, they are also called as small molecule inhibitors. So they are also called as small molecule inhibitors. So either you block the tyrosine kinase or you block the intermediate pathways. So these are called small molecule inhibitors. So like this, we started getting so many targets to kill the cancer. So one is the MAB and one is the small molecule inhibitors. So in this video, I'll be teaching you what are most important for your exams, what you have to keep in your mind. So let's start our journey. Let us start with monoclonal antibodies, MABs. In the MAB, first we'll write the target, epidermal growth factor receptor. EGF stands for epidermal growth factor receptor. Now, who will block this? The blocker of this is called cetuximab. It is called cetuximab. And where to use it? It is used in metastatic colon cancer. It is also used in head and neck cancer. Similar to cetuximab, we have one more drug, and that is called panitumumab. It is called as panitumumab. Now, where to use it? It is also used in metastatic colon cancer. It is also used in metastatic colorectal cancer. So remember, epidermal growth factor blocked by cetuximab. This is a very, very important drug. So once we are done with that, let us move on to the next growth factor. That is called HER2/neu. So HER2/neu is a type of epidermal growth factor. The drug that blocks is called trastuzumab. Trastuzumab, the major use of that drug is breast cancer. It is used in breast cancer. But one of the adverse effects of the drug is cardiotoxic. It is cardiotoxic. Recently, we have come up with one more drug that is called pertuzumab. Pertuzumab is also used for the management of breast cancer. So trastuzumab is the one which they keep on asking in the exam. It is used for breast cancer, and they will also ask the adverse effect, that is cardiotoxic. Now, blocking of vascular endothelial growth factor receptor. Now, this is very common because this is required for the tumor to survive. They require the vascular supply for survival. Now, that is blocked by bevacizumab. It is blocked by bevacizumab, and most of you know the drug. It is used in colorectal cancer. Now, do you use it in any eye condition? Take a guess. Yes, it is used in angioproliferative retinopathy. So in retinopathy, we also use that because, as the name is telling you, angioproliferative, the blood vessels are proliferating, block them. It is also used in renal cell cancer. It is also used in renal cell cancer and non-small cell lung cancer. But mainly remember, bevacizumab, one of the drug used in ophthalmology, is for retinopathy, angioproliferative retinopathy. Similarly, we have another drug which blocks the vascular endothelial factor. It is called ranibizumab. It is called ranibizumab. Where to use it? The drug is used in the wet age-related macular degeneration. Macular degeneration, and the drug is called ranibizumab. Recently, they had asked what is the mechanism of action. It blocks vascular endothelial growth factor. It is called ranibizumab. It is used in wet age-related macular degeneration. It is given by intravitreal route. So we have done with the growth factors mainly the epidermal growth factor, HER2/neu, vascular endothelial growth factor. Is there any other? Yes, there is something called platelet-derived growth factor receptor. Now this is blocked by a drug called olaratumab. It is called olaratumab. You know Ola? Tumor map. So where do you use it? Soft tissue sarcoma. It is used in soft tissue sarcoma. So these are the major maps you have to keep in your mind. Now once we targeted this growth factors, then we thought one more thing. Why can't we block the CD factor? So CD factor blocking maps. Yes, what is the CD factor blocking map? We can block the CD52. The CD52 blocker map, it is called as alemtuzumab. It is called as alemtuzumab. Now where do you use this? It is used in CLL. It is a tumor, but it is also being tried in multiple sclerosis. Not a cancer, but it is also used in multiple sclerosis. Now one more important drug they ask in the exam is the CD20 blocker. I think most of you know the drug, and the name is called rituximab. Rituximab is very famous drug, very favorite for examiner, very favorite. Now where do you use it? It is used in non-Hodgkin's lymphoma. I'll give a mnemonic for that. No match for this drug. No match for this drug. Now what is M for? M for multiple sclerosis. And it is also used in an autoimmune disorder, myasthenia gravis. Because you know that in autoimmunity, the B cells are going to act on the NM receptor, that is in myasthenia gravis. Now A for arthritis. Now which arthritis do we use it? Yes, you are right, rheumatoid arthritis. TTP, it is used in thrombotic thrombocytopenic purpura. It is also used in CLL, and also it is used in hemolytic anemia. Which hemolytic anemia? Which hemolytic anemia? If it is due to autoimmune process. Autoimmune hemolytic anemia, we can use it. The mnemonic is no match. Non-Hodgkin's lymphoma, I told you the regimen is ORCHOP, multiple sclerosis, myasthenia gravis, rheumatoid arthritis, TTP, CLL, and hemolytic anemia, which is due to autoimmune disorders. So we can block CD. Then another maps which are trending nowadays, very important. These are called immune checkpoint inhibitors. Immune checkpoint inhibitors. Sir, what do you mean by that? What do you mean by that? Now, why the cancer cells are not killed by immunity? The cancer cells have a pass. The pass is telling that we are also yours, don't kill us. If they don't have the pass, then the immunity will kill. What is that pass called? Let me write. This is the cancer cell and this is the T cell. So let me write. This is the cancer cell and this is the T cell. Now what happens? The T cell has a receptor called T cell receptor. Here the antigen is presented. When the antigen is presented, T cell should mount an immune response. Yes or no? Because it has to kill. But the T cell has to identify whether it is ours or somebody's. So for that, what the cancer cells will express, they express something called program death ligand 1. So they express a ligand called program cell death ligand 1. If that is expressed, this will combine with one more molecule from T cell, and that is called program cell death 1. If they both bind, this and this bind, the immune cell T cells will not attack the cancer cell. They will not attack the cancer cell. That is a pass for them. So you are also normal, don't worry, we will protect you. So this was learned by the scientists. See how much important research is. Then the scientists thought we'll develop a mAb in such a way that the mAb will block this ligand. If I block the ligand, then the PD1 will not bind to PD1 ligand. If they don't bind, then the T cells will mount an immune response on them. It will mount a immune response on them. So the pass will be taken up from them. So we'll take the pass from them and they are not able to survive. So that's the reason nowadays this is a trending topic, and these drugs can be used in many cancers, almost 18 to 20 cancers. So that's why this is trending topic, why they are asking you the immune checkpoint inhibitors. So number one, we have the PD1 inhibitors. PD1 inhibitor. What is the meaning of PD1? Program cell death 1. And the drugs are they're called pembrolizumab. So what I suggest you is write them and stick in your room and look into them every day. Then nivolumab. Then one more drug. It is called semiplimab. So these are also called as pencil drugs. Pencil drugs. So pencil drugs. P for P, N for Navy, C for semiplimab. Now where to use it? Uses. Now remember the uses are around 18. Should we remember all those things? Not required. So they were discovered initially for melanoma. They are used for melanoma. They are used in RCC, renal cell cancer. They are also used in Hodgkin's lymphoma. Hodgkin's lymphoma. They had asked this question recently. This came as an MCQ. And they are used in various other tumors. So there are around 18 uses, not required. Remember the pencil drugs, P for the pembrolizumab, E for nivolumab, C for semiplimab. Then the scientists also discovered one more thing, that is program cell death ligand 1 inhibitors. So it is called as PDL1 inhibitor. So what is the name of them? The name is, they are called as atezolizumab. I know that names are difficult, but don't worry. Atezolizumab. Then there is durvalumab. Then avelumab. So atezolizumab, avelumab. Where do you use them? Same uses. Same. They are used in the same conditions. Okay, so that is PDL1 inhibitor. They are called immune checkpoint inhibitors. Another immune checkpoint inhibitor is to block CTLA4. So CTLA4 inhibitor. The name of it is called EP. It is called ipilimumab. So it is also used in melanoma, RCC, and various tumors. That's what I was telling you. Since they tell the immunity to do the work, there is no need of drug only. The immune cells only will destroy them. So very good, right? So that's the trending in the future. So this is the trending what we get in the future, blocking of the PD1 or blocking of PD ligand or the blocking of CTLA4. These are called immune checkpoint inhibitors. This is the future of cancer chemotherapy. That is the future. So then we discussed the CD factor blocking maps, then growth factor blocking maps. These are all maps. And remember, as we study this drug, we think that it's easy to give them. Yes, it's easy, but the cost is the factor. They are very, very costly to the patient. And that's the reason still the older drugs are used, and that's why still the older drug questions are coming in the exams. So once we are done with that, let us understand the small molecule inhibitors. So in the small molecule inhibitors, let us understand the tyrosine kinase inhibitors. The tyrosine kinase inhibitor. So number one, we have the BCR ABL tyrosine kinase inhibitor. It's also inhibitor of c-KIT tyrosine kinase inhibitor. Now these, you already know the name of the drug, and the beautiful drug name is imatinib. So imatinib is the drug of choice for CML. One of the wonderful drug for CML. It's also drug of choice for GIST, gastrointestinal stromal tumor. Now, if there is resistant, we use a drug by the name dasatinib, and we have another drug, nilotinib. So these are used if there is resistant to imatinib. Otherwise, imatinib is a super drug for CML, GIST, and these drugs are also used for one more condition, ALL. So they are also used in ALL, imatinib, dasatinib, and nilotinib. The second target, so what we have to block the tyrosine kinase is the tyrosine kinase of epidermal growth factor. So these tyrosine kinase inhibitors, what are the name? So you write the E, G, and F. So epidermal growth factor, the drugs are Yerlo, it is called as Yerlotinib, and observe the end with nib. Then we have Jeftinib. Now since you have written already F, so add A for that. F, it is called Afatinib. So these are epidermal growth factor tyrosine kinase inhibitors, and all are used in non-small cell lung cancer. Non-small cell lung cancer. So that is epidermal growth factor. The third important one is to block the HER2/neu. It is to block the HER2/neu tyrosine kinase. It is to block HER2/neu tyrosine kinase, and the name is lapatinib. So lapatinib is there from so many years, and recently we have a drug called neratinib. So where do you use them? Obviously they are used in breast cancer which have metastasized. So metastatic breast cancer, we can use them. Usually for breast cancer we do surgery, but many a times if it is metastasized or if it is surgery is not possible, then we use these drugs. And please note down, these drugs are given oral. Number 4, you can block the vascular endothelial growth factor tyrosine kinase. So the drugs which inhibit this are sorafenib. Sorafenib is used in the management of hepatocellular cancer. So it is used to treat hepatocellular cancer. If you know Sora, you should know Suni. It is called sunitinib. So sunitinib is used to treat imatinib resistant GIST cases. Sunitinib. And one more is called regorafenib. So you read them, they end with fenib. One more is sun, sora, suni, regora. Now regorafenib, it is used to treat colorectal cancer. And also it is used in sunitinib resistant GIST, gastrointestinal stromal tumor. I know these are all factual. There is no concept to tell you. It's all factual. So imatinib is a drug of GIST. If it is resistant, we give sunitinib. If sunitinib is resistant, we give regorafenib. That is a flowchart for this. Now, the fifth one, we have something called ALK. ALK tyrosine kinase inhibitor. The name is called, what is the name? You know, Alexa. It is called Alextinib. And one more is Crizotinib. So these are used for non-small cell lung cancer. Yes. So what we discussed till now, they are all the inhibitors of the tyrosine kinase. But we can also block the intermediate pathway I told you. You can also block the JAK1 or 2 inhibitor. And you know that JAK inhibitors are used in rheumatoid arthritis, but we have a JAK inhibitor. The name is called ruxolitinib. Ruxolitinib. And we use it in the treatment of polycythemia vera. Polycythemia vera. Can you tell me one more drug which is a cell cycle specific drug used in polycythemia vera? Yes. If you're telling hydroxyurea, you are correct. So that is the point. The next intermediate pathway which we can block in cell proliferation is called the BRAF inhibitors. So we have BRAF inhibitors. What are the name of them? The name of them is Vemurafenib. They are called Vemurafenib. Vemurafenib, and you see the RAF in their name. And one more is Dabrafenib. Again in the name you have RAF. Now where to use them? These are used to treat melanoma. So the BRAF inhibitors are used in managing melanoma. Then we have something called proteasome. The role of proteasome is to cause proteolysis. So there are drugs which are proteasome inhibitors. We have proteasome inhibitor. And what is the name of them? They end with zomib. For example, Borte. It ends with zomib. Zomib. So the proteasome inhibitors, they end with zomib. Then we have ixazomib. Then we have carfilzomib. So we have bortezomib, ixazomib, and carfilzomib. So they end with zomib. And where to use them? They are used to treat multiple myeloma. Multiple myeloma. For multiple myeloma, we use a regimen. The regimen usually includes bortezomib plus lenalidomide, which is similar to thalidomide, plus a steroid. A steroid is dexamethasone. So this proteasome is also inhibited, and they end with zomib. So that is also intermediate pathway. Then you can also inhibit cyclin dependent kinase. Cyclin dependent kinase, we call them as CDK4/6, that is inhibited by the drugs called, it is called palbociclib. So they end with C-clib. Cyclin dependent kinase inhibitor, they end with C-clib. And where to use them? They are used to treat breast cancer, mainly for breast cancer. One more important inhibitor, PARP inhibitors. PARP inhibitors. What do you mean by PARP? They are nothing but ADP, ribose, R for ribose, P for polymerase. Now this is inhibited by a drug called, olaparib. So they have taken PAR from here. It ends with PAR, poly ADP ribosome inhibitor, ribose polymerase inhibitor, and that is olaparib. This olaparib is used for two cancers. One is breast cancer in a female, and one more is the ovarian cancer. So breast cancer and ovarian cancer it is used. The last one in the target is the histone deacetylase inhibitors. Histone deacetylase inhibitor and end with stat. For example, vorinostat. Vorinostat, it is used in cutaneous T-cell lymphoma. Then we have another drug called panabinostat. Now usually the enzyme inhibitors are ending with stat. So this is used in multiple myeloma. One more histone deacetylase inhibitor, and the name is called ROMI. It is called romidepsin, and it is also used for CTCL or PTCL. So either the cutaneous or peripheral T-cell lymphoma it is used. It is called as romidepsin. So these are all the small molecule inhibitors which are very, very important for your exams. Okay. So there are plenty of targeted therapies, but what is high yielding should be learned for your exam, because if you read so many things at the end, you will not remember any of those things. What I suggest you is target therapy should be read in the end. Once you know the basics of pharmacology, you know the basic drugs. Once you have time, then only come to this topic, targeted therapy. So I filtered out all the important ones and I put that here so that you can memorize the things. So what I suggest you is make a chart, fix it in your room, study that every day. That's the best way to remember these drugs. Or whenever you are reading pathology, when you are studying surgery, then at that time you read anti-cancer drug, it becomes easier for you. So that is about target therapy, the future of anti-cancer drugs, and the future is immune checkpoint inhibitors. If they come into the market, you can cure the cancer like anything. But the only factor is the cost factor. So that is about target therapy. Thank you all.